The following total laparoscopic hysterectomy video is presented by Dr. Paul Blahoff. This is a case of a 45-year-old female. She is A, P2, G2 with 2 cesarean sections in her obstetric history. On MRI, a large pelvic solid mass 12.7 by 12.6 by 18 centimeters size, most likely a large uterine fibroid. The procedure begins with the division of the left round ligament, extending the incision parallel along the left IFP, and opening the left broad ligament. Opening the left broad ligament continues caudad. Peristalsis helps to identify the ureter. The rhythmic contractions of the ureter are visually distinct and characteristic. These contractions allow the ureter to stand out. The internal and external iliac vessels are identified. Opening of the pararectal space. Once again, peristalsis of the ureter help to identify it. Highlighted is the pararectal space. Here the left ureter and left uterine artery and vein are seen in one view as highlighted. Bipolar energy is used during the coagulation of the left uterine artery. Having sealed the uterine artery, the uterus now appears more pale. In this zoomed-out view, the small uterus can be seen riding on the huge cervical myoma. The right ureter can clearly be seen. Coagulation of the right ovarian ligament close to the ovary. Coagulation and division of the right corneal pedicle. Opening of the right broad ligament. Coagulation and division of the right round ligament. Here we can appreciate the course of the right ureter, as highlighted. Dissection and cutting of the right posterior leaf of the broad ligament. Limited access to the right broad ligament due to restricted space caused by the large myoma. Dissection of the right ureter was performed while attempting laparoscopic uterine artery ligation on the right, but the procedure failed due to limited space caused by the myoma. Careful dissection of the left adnexa, including the ovary and fallopian tube, was performed to separate it from the uterus. The small uterus is now clearly visible, positioned atop the large myoma, with the left adnexa completely separated from the uterus and reflected laterally toward the pelvic sidewall. The adnexa was then gently mobilized and reflected laterally to improve surgical exposure while preserving vascular integrity and minimizing tissue trauma. The myoma screw is now being utilized to provide traction, allowing for better visualization. This maneuver enhances exposure, facilitating a more precise assessment of the surrounding structures and aiding in the surgical approach. Incising the vesicouterine peritoneum and performing a caudal dissection of the bladder to create a clear surgical plane. This allows for the safe separation of the bladder from the lower uterine segment, reducing the risk of injury. Careful dissection is performed to ensure adequate mobilization, providing better access for the next steps of the procedure. Hemostasis is maintained throughout to minimize bleeding and improve visibility in the operative field. A combination of diathermy and traction is placed on the right medial umbilical ligament as the peritoneum is dissected. Dissection and isolating of the ascending branch of the uterine pedicle. An injection of vasopressin, at a concentration of 40 IU, diluted in 400 milliliters, of normal saline, directly into the myoma. This procedure aims to reduce intraoperative bleeding by causing vasoconstriction of the surrounding blood vessels. The solution is carefully injected into the myoma tissue under sterile conditions, ensuring precise administration to achieve optimal hemostatic effect. Starting dissection of the myoma, using scissors and a combination of traction, countertraction, using the myoma screw, and laparoscopic tenaculum grasping forceps. Careful dissection and enucleation of the myoma from the surrounding uterine tissue, using a combination of blunt and sharp dissection to separate the fibroid from the myometrium, while preserving healthy uterine tissue. Once the myoma is adequately mobilized, it is gently shelled out using a combination of traction, countertraction, and hemostatic measures to minimize bleeding. Care is taken to identify and coagulate feeding blood vessels to reduce intraoperative blood loss. Insertion of a swab mounted on a stick into the vagina, to aid in defining the completion of bladder dissection. This technique helps provide clear visualization and identification of the bladder's boundary, ensuring precise surgical dissection and minimizing the risk of bladder injury. Colpotomy is performed using a harmonic scalpel, an advanced ultrasonic energy device that enables precise cutting and coagulation while minimizing thermal damage to surrounding tissues. The harmonic scalpel facilitates precise tissue dissection while simultaneously sealing small blood vessels, reducing the risk of excessive bleeding and improving hemostasis. The specimen was separated from the vagina by cold scissors. The cervix appears very dilated and difficult to determine where the cervix ends and vagina begins. After completing the colpotomy and ensuring adequate exposure, the small uterus was carefully mobilized and removed through the vaginal route. Gentle traction and appropriate surgical techniques were employed to facilitate smooth extraction while minimizing trauma to surrounding structures. Further downward dissection of the bladder. Introduction of the vicryral suture through the working port, using backloading method. Suturing of the vaginal cuff was initiated to close the colpotomy incision. Absorbable vicryral sutures were used to approximate the vaginal edges, ensuring secure closure. Adjusting the needle to the proper alignment to facilitate smooth and secure knot tying. A final irrigation and suction with warm saline was performed to clear any remaining blood or tissue debris. Gauze was introduced for hemostasis. Open morcellation of the cervical myoma. Inspection and removal of all the small pieces of tissue completes the morcellation. Introduction of the suture for the final step of the operation. Peritonalizing of the operation site by suturing the pouch of Douglas peritoneum to the vesical peritoneum covering the center, and removal of the swab. Inspection and placement of the drain, and final washout completes the surgery. Thank you for watching. At the end of the procedure, the specimen was weighed in the operating theater, with a total weight of 1,170 grams. Therefore, the cervical myoma weighed 1,100 grams. The patient was discharged at day 3 post-op. There were no complications. This has been a presentation by Dr. Paul Blahoff. Thank you.